So I'm going to hand over a slight change of direction now. I'm going to hand over to Meredith, who's going to talk to us about physiotherapy. So thank you.
Thank you. Oh, good. I'm glad Lindsay's on the tech support. I'm Meredith James. I'm a physiotherapist. I also work in Newcastle with Volker Straub. For those that are familiar with British accents, I don't have one. I come from the home of the Sydney Harbour Bridge, which is in fact 3 times higher, longer and wider than the Tyne Bridge, and was commenced prior to the Tyne Bridge, but because of its size was actually finished 4 years later. I've just got a little bit of time to talk to you about physiotherapy considerations in FKRP limb-girdle R9, limb-girdle 2I. And I'm just going to review a little bit about outcome measures. You'll hear from other speakers today about natural history studies and clinical trials, and we'll then have a little talk about physiotherapy considerations. Today, when you are presented with lots of information from the clinicians and scientists in the room, you will hear about outcome measures, and you might wonder, well, what are those? They're all the things that we ask you to do, or ask you to write your opinion about, or put you in an MRI scanner, or measure your lung function. And as clinician scientists, we want to monitor those over time so we can best understand how the disease is affecting your life, and in order to inform pharmaceutical companies about what are the best outcome measures or the best assessments to show change in a drug trial. And we also like using these, as you've seen from Lindsay, in the registry, because for those people that aren't involved in a clinical trial or a natural history study, we can use the registry to help us do more research to best understand the condition and make sure, as the clinicians, that what we do is reflecting the difficulties that you may be experiencing because of your disease. But it's not always easy. As scientists, we're a little bit like Goldilocks and the Three Bears. And so we've got lots of different tests, but we're still trying to understand which is the most appropriate one for which person at which stage of their life. So sometimes we have tests that become too hard very, very quickly. So something like getting up off the floor is not a test that is good for you for the entire course of your disease, because that's a task that's really difficult. We've made some newer tests that try and address this problem by looking at difficulties both in lying down but also in standing and walking. And then we've also been trying some other tests, which this one, the 9-hole peg test, for anyone that's participating in one of the natural history studies, it's a little board with 9 very slippery little white pegs, and there's 9 holes, and you've got to take them out and put them back really, really as quickly as you can without dropping them all over the floor. But what we know now from using that test in a natural history study is it's probably not a great one for FKRP. So we can inform the community that that test to use in clinic or in drug trials or in natural history studies probably isn't very useful. What we have been doing in the wider limb-girdle community is trying to make better outcome measures or better assessments. And so this one, the North Star for limb-girdle type muscular dystrophies, is a test for both people that are walking but also people that are wheelchair users, and so it follows you through the course of the disease. And we've been utilising natural history studies and patient events such as this to collect lots of data on lots of people with different types of limb-girdle to make sure that that test is appropriate. And this is going to be my shameless plug already. There is physiotherapy natural history study happening at the conference this weekend. We're in a room off in the corner that way. We're in the Leeds room. And so if anybody feels able to contribute to that natural history study, we would love to see you. We are here all weekend. We are happy to have you come and join the chaos and inform the science. But why? Why do we need those data? So we do work as a good international community of clinicians, and you will hear about all of the exciting research that people are doing in their centres, but you have an ultra-rare disease. So and not everybody goes to a centre that's in a drug trial or in a natural history study. So by utilising patient events, we can capture lots of you that we might not otherwise have information from. And that helps us with your diagnosis or diagnosing people in the future. It helps us understand as clinicians, when you go to clinic, well, what should we be asking you to do? What's actually useful? What we want to do is populate a crystal ball so that we can give you more time to understand how things might change in the future, to give you time to adapt. It also helps us answer questions about, well, what might be the best exercise, or what might be the best splint to help walk? What's the best thing to do in the home? And then that informs standards of care so that we can come up with international agreed sentences and put together a document that you can take as a community to your clinician if they're not an expert in LGMD2I and say, well, actually, this is what the experts say I need to have. I need to have my lungs measured, my lung function measured every year. I need someone to check my range of movement. I need to see a physiotherapist. But it is a team approach. So you are at the centre of this, and then we need to make sure that you all have access to the right healthcare professionals at the right time to make sure that everything's being managed very carefully. So my role as a neuromuscular physiotherapist, I see patients in clinic and in our natural history studies and our clinical trials, and the things that I am interested in that I want you to tell your physiotherapist about is how you are going in life, how you are managing getting out of the bed in the morning, how are you managing in your work environment, can you park your car close enough to the office, how's your mobility, how's your breathing, how's your sleeping, how are you doing with your arms, how's your participation around, is your world getting a little bit smaller because walking's got a little bit harder. So those are the sorts of things that you should be able to discuss with your physiotherapist so that we can look at exercising, how all your joints are moving, and when you can't move a joint anymore, then it's really good that someone can help you move that joint so it doesn't get stiff. Looking at orthotics or bracing, splints on the legs, but it also could be in the upper limbs. Mobility aids, which is a very sensitive and personal discussion to have about when is the right time to think about maybe using a walking cane or a hiking pole and then coming into wheelchairs and all the life changes that brings as well. Fall management is critical. If you do fall down, how are you going to get back up again? And home aids and adaptations. So exercise, I think I've jumped a bit too far. Exercise, it isn't just going to the gym, lifting heavy weights or running several kilometres on a treadmill. It's your daily activity. It's not just having to do what we think of as traditional exercise. We want people to be doing something that's active, that makes them a little bit short of breath, and doing something is better than doing nothing. Exercise prescription is like medication prescription. It's individualised to you. There's no point a physiotherapist prescribing you hydrotherapy if you don't like the water and you don't like swimming. So we need to come up with things that you enjoy, that we think would be working in with your abilities, and ensure that you don't overdo it or push yourself too hard. We do have a nice, there's some nice exercise studies, some research that's been done that's showing that exercise is safe, and we're just working on refining what would be the best prescription for that, but something is better than nothing. And it doesn't have to be on your feet. If you are a wheelchair user and being on your feet isn't possible or safe, there are other options. We're learning from our Duchenne muscular dystrophy community about being able to use arm exercising tools that are really nice and safe. They're also good for getting your heart rate up. Some of our colleagues from London and also from Iowa have created some excellent online resources, which is home-based Pilates and yoga videos. And these can be done in sitting or in standing or in lying on your bed or lying on the floor if that's still possible. When we think about joint mobility, we know that the calf and the ankle can be a bit problematic for a lot of people. And so our traditional physiotherapy, let's just get someone to stretch your ankle and hold it 30 seconds 3 times once a day, isn't enough to stop an ankle getting tighter and tighter. So we need to think about what your 24-hour day looks like. And if you're a wheelchair user and you spend 16 hours in a chair, we know that you're likely to get a little bit tight behind your knees, maybe in your ankle and your hips. And so it's just finding things throughout your 24-hour period that we can do to try and minimise those secondary complications. Some people use standing frames, some people use splints, some people have a combination, but it's just thinking about what you do over your 24-hour period that we can help put some little things in place that work. In terms of splints for walking, there is not one size fits all, and a splint that you have for one period of your life may not be the splint that you keep using. So this changes over time. What I would say is less is more. So we tend to start with less restrictive. We don't tend to use the traditional hard plastic type splints on people's legs anymore because it actually often makes walking harder, not easier. But those are some of the options that if you are having difficulty walking, that you ask your clinicians to make sure that you can see an orthotist and a physiotherapist to discuss different things to try. We can't forget the upper limb, and particularly for women, trying to put on a bra can become really, really difficult. Here at the conference, there is a board, and Heather might be able to tell me where it is, where we're going to have the life hacks and top tips. And so, as a community, you're amazing at sharing all the things that you found work for you. And so we borrowed from the Iowa conference from Kathy Matthews, who also run this incredible life hack session. And we've done this in the Limb Girdle conference in America as well, and sharing pieces of equipment or different hacks about travelling and things like that. So that board will be somewhere. There's lime green post-it notes for Limb Girdle, ready to be stuck on walls so that we can collate those top tips that you can share as a community and then make them available to people. But there's upper limb considerations. Zip front bras are often a little bit easier than trying to put on something that hooks at the back. If you are a long-term wheelchair user, particularly women who are menopausal, we need to think about bone density considerations. One of my patients has very kindly sent us the photo of her sit-to-stand riser that we double up as a standing frame, and it can be wheeled out onto the veranda for the one day a year in the UK that we get sunshine that she can enjoy for her vitamin D as well. There is a number of ways that we can look at doing, if this is something that is important to you, that we can look at doing supported standing. But what is critical, and what I feel our role is as physiotherapists, is helping you maximise your independence and doing that safely. So looking at mobility equipment. In our communities now, and wherever you are in the world, when you're trying to walk around out in the street, everybody has their face in their phone and no one is paying attention. And if you have some difficulties with your balance and someone knocks you and you have a fall, this can be a really big problem if you can't get back up again without using furniture. And so thinking about when walking is becoming a little bit difficult, just having options, having a toolbox of things that you, not necessarily a physical toolbox, but having options in the cupboard that you might be able to take out with you. So we often find that the Nordic-style walking poles, so the higher walking poles that are telescopic, so they can fold up and go in your backpack like an umbrella, or definitely with your umbrella if you're in the UK, are really useful. If you have something on your person, like a walking pole or a walking stick, people will give you a little bit more space and they are less likely to crash into you when you're using your phone. I'm glad to see some nodding heads here. It's just having that just a little bit more space so that if you do lose your balance a little bit, you've got a better chance of staying up on your feet. At some stage for many people, there will be the need to transition into powered mobility or manual mobility. We can look, there's obviously lots of different options. Each country is very specific. We've had 26 physiotherapists come here on Thursday to share from 14 different countries around Europe and Argentina and the States to share practices. It was amazing to hear some of the countries that have really appropriate limb girdle wheelchair prescription where a seat elevator is just part of the standard prescription. So not only can you drive your chair, but you can actually get out of it by yourself, so you can walk to where you need to go. And that's the sort of basic level of prescription for a wheelchair that all countries should be allowed to expect, but something that as a group of clinicians, with the patient community, when we write standards of care, a seat elevator is a really critical thing if you have R9. Going to the toilet. If you can't get out of a chair and you're struggling to get out of a chair, then your world can become a lot smaller for a lot of time, because if you want to go to a restaurant, you don't know if you can get in it, you don't know if you can sit on the chair and get back out of it again. Those long benches that are very trendy in lots of places at the moment can be very difficult. And so thinking about toileting, before we're thinking about the toilet, we're thinking about how are you getting out of a chair and what are you sitting in, and is it the right height? Have you got a little rise, options to get out of the chair, portable things? Going to the toilet is a basic human right. And so making sure that you have access to physiotherapy and occupational therapists who can advise on aids and equipment to help in the bathroom, wet rooms, raised toilets, grab rails and all the other pieces of equipment. But then toileting when out in the community, it's obviously a lot easier if you're a bloke, but if you're a woman who is a wheelchair user, Kat was sharing some fantastic practice yesterday about using portable female urinal devices. There are many more of these now, and there's some that you can use in standing, some you can use in sitting, and also ones that can be used multiple times overnight, so that you have a little bit more independence in toileting overnight as well. They do take a bit of practice. And the right clothes, yeah. Tight leggings is not the way to go with a shiwi, definitely. So this is, again, something to discuss with your healthcare professionals, because and there's a lovely, if any of the Danish colleagues are here and patients, the Danish group have just done a fantastic piece of research about surveying urinary habits of women with muscle disease. It's called the HAPPY Project, and it's been published on a patient and professional educational website run by my colleague Dr. Anna Mayhew, which is called pod-nmd.org. I'll put it up later. But this is about making sure that people can get to the toilet. Also within the bedroom, if you can't sit yourself up out of bed in the morning, then you can't get out of bed and you can't be at home by yourself. So thinking about what aids and adaptations will maintain your independence so that you can easily sit yourself up in bed, how you can change position. If it's getting a bit hard to turn your hips, looking at using slide sheets, or if you want something less medical, and I think Kat's just gone out the room, she sewed satin pillowcases together. We would advise not using satin sheets because you may just end up sliding out of the bed completely, but something under your hips that just gives you a little bit of ease, more ease to turn over is very useful. Very high count cotton sheets, if you like things that are a bit luxury. High count cotton sheets are actually a little bit slipperier and easier to turn on as well. What we know in limb-girdle R9 is that getting up out of a chair is going to become difficult even before walking becomes difficult. And so making sure within your home that you have multiple options, and within your workplace that you have options of how to independently get up out of a chair is critical. This tilting recliner chair that's up there in the middle, this one, these standard riser recliners are a complete disaster because you can't lock your knees when you get up, so they kind of just catapult you out. Not all risers are built the same. So if you are talking to your occupational therapist and they might be used to working with elderly people or people after a stroke, you need to be very specific that I need a seat that goes up first before it catapults me out, because I need time to tip on my feet and get my back straight and get my legs locked out. So yes, not all sort of adaptive equipment is built the same. Some people do like using, I think it's an Up Easy. It is a bit of a tilting seat, but it's portable. So if you are trying to be out and about, having your social life, it does give a good option if you've got something like a solid table in front of you that you can then lean on. Bar stools are great because you can just you can just slide off, you can just tip yourself off and on them. So I think particularly in the States where, going to a bar and being able to have lots of stools is a really nice option and makes things a bit easier than getting out of a normal chair. Fall management. Prevention is key. This isn't something that we should be discussing as clinicians with you reactively after you've had a bad experience with a fall. There are lots of different pieces of equipment. Most of it may sit in the cupboard for months or years, but at least if you have it proactively and a fall management strategy, if you do fall, can you get yourself back up? If you can't get yourself back up, or if you fell in the middle of a room and couldn't crawl somewhere, have you got some sort of lifting cushion? Have you got a smart speaker that you can yell out to Alexa, Google, Siri, whoever, and say, please call a family member? Apple watches or other watches that have fall detections, fall alarms, which is less common because now we have all these other options for digital tech. And we can, as physios in clinic, we can have a look at your fall risk by looking at how you're moving and doing some really simple things, and then having that discussion about making sure the occupational therapist has been to see you at home to give you the aids and equipment that might be appropriate. Environmental controls and just the availability of voice-activated things, the lights, the front door, hand controls on vehicles, different adaptations in the car for driving from a chair or not driving from a chair. All of this technology is out there and available. And again, there's a community. You are really good about sharing what things might work. If you don't necessarily want to drive with hand controls, there's also adaptations to foot controls that make things easier than you trying to lift up your leg and move it between the pedals. Occupational therapists are critical. We have an occupational therapist that will be around in some of the patient focus sessions this afternoon. Things like travelling with a little piece of non-slip mat. If you don't know what a hotel bathroom is going to be like, or your friend's bathroom, travelling with a little piece of Dyson for the bathroom floor can be really useful. Low stools are really nice for resting your feet on if you've been in your chair all day and in that chair-shaped position. There's lots of different options out there. Home adaptations should be done in conjunction with an occupational therapist, and again, they may not have great experience in things that are specific for limb girdle, but if you involve them with your clinical team, you should be able to have a really good discussion about what in a bathroom might work quite well, or figuring out the combination of if you want a washer-dryer toilet, like a Japanese-style toilet, but you also need a seat riser. How does that work? And how does that work with different restrictions about power in the bathroom and things? Limb Girdle Awareness Day, great day at the end of September. There's lots of resources there, particularly if you're after the top tips. If you Google Iowa Wellstone Conference and you go into the patient information, there's a lovely, and if anyone needs a direct link, Kathy's in the corner there. I also have it. But you can just Google it and find all these top life hacks. Pod NMD is a really great clinical resource, which is education for patients and clinicians who work with patients with muscle disorders. It's not limb girdle specific, but it has a limb girdle section, and it has some really nice podcasts and things as well. We also have some podcasters in attendance today. Keris, put your hand up. Keris has her own podcast, which I'm sure she'll be delighted to talk to you about, which is another excellent resource to hear about lived experience with someone with R9, getting on and just getting on with life. We can't do any of this work, particularly our scientific work or improving our clinical care, without you, our patient experts. Again, shameless plug, come see us in Leeds today if you want to have a chat or if you want to partake in the physio natural history study, which informs the assessments that will be used in clinic in the future. And a big thanks to all our sponsors, not only for the meeting today, but also for allowing the physiotherapy colleagues to come together earlier in the week and talk about limb girdle and shared practice. Thank you.